everyone. So, this week we're going to start by talking about healthcare and the economics of healthcare. Um, just to give you an idea of where we're going, we're going to start by kind of looking at some of the challenges that health economists face, what makes health economics kind of difficult. Then we're going to zoom in on the U.S. healthcare system and talk about kind of some of the major issues with it, while making reference to some other national systems. And then we're going to talk about paying for healthcare and the different ways that different countries do it, and largely this is through pooling, which has some interesting consequences. And then finally, we're going to look at some of the behavioral factors that influence the supply and demand for healthcare. Some challenges facing health economists. There isn't just one market for healthcare. There's a bunch of different markets for healthcare, and these markets are geographically distributed, but also very specialized, right? Very specific. So we can't just think about an overall market for healthcare. There's many markets that are all kind of fragmented across an entire country. And a lot of things that health economists examine don't really have market prices. So, for instance, it's very difficult to value how much an additional year of life will be, or the consequences on quality of life of getting or not getting a particular procedure. And so these things don't have easily definable market values, and so there is a lot of estimation involved to try to kind of suss out what the value of these things are. And finally, even basic medical procedures that should have some sort of market price don't often have a single market price. There's a lot of price discrimination that goes on in healthcare, and so it's sometimes hard to just know what the price of something is, because that price changes based on the qualities of the individual consuming the healthcare. So, moving on to the U.S. healthcare system specifically, the U.S., like most nations, has some sort of mixed system. We fund our healthcare through both private and public means, and we pay a ton for healthcare in the U.S. So this graph represents spending as a percentage of GDP for different countries. The total height of the bar is total healthcare spending. The green section is public spending, and the light blue section is private spending. And you can see that we are far and away the largest spender on healthcare as a percentage of GDP among these countries and in the entire world. We've just kind of limited the sample here to comparably rich, developed countries, so lots of European and European offshoot countries. And you can see here that the U.S. spends 8.5% of its GDP just in public spending, and more than that again in private spending. And if we look, the United Kingdom, famous for its National Health Service, a fully government-owned and operated health service that has universal coverage for everyone, they spend less as a proportion of GDP on public spending, and they have an entire national health service. And the U.S. then spends even more on top of that in private spending. So this really high level of spending actually wouldn't be a terrible problem if we received really, really great healthcare in return. But it doesn't seem like we do. We tend to have worse outcomes than most comparable countries. Life expectancy is lower, infant mortality is higher, and access is significantly worse. So this chart shows life expectancy in a bunch of developed countries from 1980 to 2017. And you can see that back in about 1988, the U.S. kind of separates from the rest of these developed countries, and we can see that among these we have the lowest life expectancy of 78.6 years. Canada's life expectancy being almost a full 4 years longer. And I mean, certainly the U.S. doesn't have the lowest life expectancy in the world by far, but we're talking about comparably developed countries. This chart shows that the U.S. has a larger percentage of their citizens living with a chronic disease. So that's what the chronic disease burden is. U.S. 28% live with some sort of chronic disease compared to, say, the UK with 14%. Canada's kind of in between these European countries and the US at 22%. And you might think, well, okay, well, maybe we pay more and we get more, we have more doctors because there's more, doctors can make more, so there's more incentive to have doctors. But Americans visit the doctor less frequently and they have fewer physicians. So if we look on the left, there's physician visits per capita, per person. And the U.S. is at 4, where the OECD average is 6.8. So this would be annually. And then we can see that the U.S. is at the bottom of this bundle of countries for practicing physicians per 1,000 population, so only 2.6 doctors per 1,000 people. And so I think it's often in the rhetoric around, say, introducing a single-payer system, the idea is like, well, doctors' compensation will go down and we'll have less doctors. But it seems like these other... not to say that all of these countries have single-payer systems, but many of them do. And so they've definitely found a way to solve that issue, to continue to give doctors incentives to be doctors. And also, mental health is far worse in the U.S. We've got the highest suicide rate among this bundle of countries, comparably developed OECD countries. And our suicide rates more than 2% higher than the OECD average. So that's kind of another element of care. So some of this can be chalked up to lifestyle, though, right? People in the U.S., they have worse diets. They engage in more risky behavior and have more accidents. They sleep less. They exercise less. And so all of these things also have an impact on health. Deep inequality may also play a role. For instance, people that are lower on the socioeconomic ladder tend to, controlling for other factors, have higher rates of stress, anxiety, heart attack, high blood pressure. And so these things are highly related to like social stress too. So anyway, it's not all healthcare, but certainly some of it is. So it's difficult to kind of suss out what percentage of our poor outcomes are because of our crappy lifestyle and what percentage of our outcomes are because of our crappy healthcare system. So we need to keep that in mind, that fixing the healthcare system will likely not completely close the difference in outcomes between the U.S. and comparable countries with more robust healthcare systems. Access is a huge problem in the U.S., where the primary barrier is ability to pay or access to insurance. A full half of bankruptcies in the U.S. are because people have medical debt, and of those people that go bankrupt because they have medical debt, 3/4 of them have insurance. So it's not a problem of, uninsured people are going out and getting expensive care, and then they go bankrupt. No, like, insured people go bankrupt because of this too. And so back with the Obama administration, the Affordable Care Act was an attempt to increase access while keeping the fundamental structure kind of intact. And the ACA did a lot of things. This is a very incomplete list. It is a huge piece of legislation. The most prominent thing was the individual mandate, right? Everyone in the U.S. was required to obtain some form of health insurance or pay a penalty. This has now been functionally abandoned under the Trump administration. The penalty technically is still there, but it's cut to 0. Some states assess their own tax penalty for not having insurance, but it's very few and far between. The ACA also created public subsidies for private insurance. So this is like the subsidies that a lot of people receive on the healthcare marketplace. It increased access to government-provided health insurance, so it expanded eligibility for Medicaid, so the public insurance program for low-income people in the U.S. It also closed a number of gaps in Medicare, particularly with respect to prescription drugs. And it also did a lot of rule changes. So, for instance, the insurance companies could no longer deny people for pre-existing conditions, and children can remain on their parents' insurance plans until they turn 26. And these are very, very popular parts of the law that I think even many people that opposed the law in general largely like these elements of it. So the ACA helped a lot. We see it in the data that more people are insured, but it didn't fix the system. We still pay more and receive worse outcomes. And there's still a huge number of people that are without insurance now, especially that continue to not have insurance, and even with insurance tend to be underinsured. So what's the alternatives then? Well, a kind of market fundamentalist idea would be, well, let's just have people pay for their healthcare directly, and things will have prices and competition will sort it out. And so that would be like a full market-based system. Basically, no country on the face of the planet uses a system like this. There's always some degree of pooling or subsidization because people tend to not have perfect knowledge about their consumption of healthcare in the future, and so they don't tend to save enough for that eventuality. And even if they did, like it's uncertain. They lack knowledge. Likewise, there's kind of the tension between healthcare being a commodity and a right, and there's kind of a large public perception that we should provide healthcare to people even if they can't afford it. Even in the U.S., for instance, with compulsory service at emergency rooms, regardless of ability to pay. And so the market-based approach really is kind of, it seems a dead end in a pure market-based approach. And so most countries engage in some sort of pooling. This pooling could be public or private. So in the U.S., there's public pools like Medicare and Medicaid, and private pools like the large insurance companies. Another pooling system would be a single-payer system. That's where a single entity acts as the insurer for all people in a country. And this is what many of those nations in those earlier graphs have. Usually this single payer, actually in practice always the single payer is going to be the government. So it would be government-provided health insurance. And this single payer system is the same thing as like the Medicare for All proposal that's floating around in the U.S. Another form of pooling is the nationalized system, and that's what the UK has. They have a national health service, so doctors don't work for themselves or for hospitals. They work directly for the government, and so it's a government-owned and operated enterprise. And so that, in a way, is kind of the furthest away from a market-based system as you could go. But in practice, most countries have mixed systems. They've got public pooling, they've got private pooling. Germany is an excellent example of this. So is France. There is a mix of government and private pools. And so why does everyone pool? Other than those reasons I talked about before, well, pooling gives you market power. Healthcare suppliers have monopolistic power. Pharmaceutical companies have patents. Natural monopolies are rampant. Like, for instance, if somebody's having a heart attack, they can't exactly shop around for which emergency room they're going to be taken to, right? And so there's a natural monopoly. They're going to be taken to the nearest hospital. And there's also knowledge asymmetries, which we'll get into more detail on near the end of this, where essentially providers have more knowledge about the needs of the patient than the patient does. So there's a big kind of market power on the supply side. But just like we talked about with labor markets, you can have monopsony power. If you're a big buyer of something, that also gives you power. So demand pooling creates this monopoly power, which kind of is able to push back against the monopoly power of healthcare providers. For instance, take an example from the US, insurance companies get lower prices from hospitals than isolated individuals who are paying for their own care do, because they're able to negotiate that rate down. Governments and single-payer systems have immense monopoly power. Like even in the U.S., where we have a very limited scope for public insurance, Medicare and Medicaid are able to negotiate far lower prices than individuals or private insurance companies, just because of just how much healthcare those programs purchase. It's also very important to note that even very market-oriented systems like Sweden have substantial price regulations. They recognize that suppliers have market power, and so they place regulations on prices to prevent them from exercising that power. So in the US, the demand side tends to be quite fractured. We've got this mix of public and private systems, but we've got many different public systems, many different private systems. And so there's less monopoly power to push back against the monopoly power of the providers. Pools do create an issue with adverse selection if they aren't universal, if they aren't the entire population. So let's think about private insurance companies in the US. Insurance works by spreading costs across people. Those with high use are subsidized by those with lower use, in effect. But people are in those pools because they suspect that sometime in the future they will be a high use. And so it's kind of like they're subsidizing other people's care early in their life cycle to have their care subsidized later in their life cycle. But if these pools are optional, then only the sickest groups will join them. And then that will make the cost of joining those pools much higher because utilization rates within the pool will be much higher. And the healthiest will opt out. And so this increases the burden on each individual that's in the pool if healthy people don't also buy into the pool. And so in the US, the individual mandate was a policy concession to insurance companies to get them to agree to a law that would not let them deny people for pre-existing conditions. Because essentially, the denial for pre-existing conditions was an attempt to keep high utilization people out of their pools, and the only way they can kind of finance having those people in their pools without making insurance incredibly expensive is to also make sure that healthy people buy in the pools too. So the individual mandate was designed to force people to buy insurance so that the overall utilization rate in these pools would fall. All right, so we've talked about pooling, we've talked about different systems. Let's kind of dig into the microeconomics of this a little bit more. So something that's made a huge deal of in health economics in the US is moral hazard. So you've probably heard of moral hazard in the context of, say, finance, where a large bank or a large investment bank may engage in more and more risky investments because they've got an explicit or implicit agreement by the government to bail them out if they get in trouble. So they do riskier things that yield higher profits in the short term. In health economics, it has a bit of a different definition. In health economics, a moral hazard is when an individual consumes more healthcare because they have insurance. So you can think about it in terms of if somebody has insurance that is observed by them as a fall in the price of healthcare, and so they consume more of it, just like any other commodity. And so this kind of came out in, I believe, late 70s, early 80s, and has been a huge part of the design process for insurance plans. So, for instance, larger copays. So you and cost sharing and larger deductibles. These are all attempts by insurance companies to make consumers pay a larger portion of their healthcare up front so that maybe they'll be more efficient consumers of healthcare. They'll consume less of it. Once again, if we think back to the pools, they're trying to reduce the utilization rate in their pools. And moral hazard is usually thought of as inefficient. So individuals pay less than the true cost of providing healthcare because the insurance company pays some portion of it as well. So they overconsume it, and this overconsumption bids up the price and contributes to the overall high cost of healthcare. But that's not exactly the whole story, and so a lot more attention has been paid to moral hazard in recent years, and there's been some acknowledgement that it may actually be efficient in some cases. So just to remind you of maybe some principles of economics concepts here, whenever a price changes, for instance, let's say the price of, let's keep it simple, apples falls. So the price of apples falls. You consume more of them, assuming they're not an inferior good. And you do this for two reasons. One is because the price has fallen relative to the price of other commodities. But also, you're now spending a smaller proportion of your income on apples, which makes you feel richer. And so these two effects, one is the substitution effect that's rooted in price, and the other is the income effect rooted in income. And so, depending on if the income or substitution effect is dominant, then that can determine if moral hazard is efficient or inefficient. So here's an example from this 2007 paper by Newman. So suppose that someone is diagnosed with breast cancer. Without insurance, she pays $20,000 for a mastectomy and then considers paying $20,000 for breast reconstruction, but has too many other competing costs. With full coverage insurance, she gets the mastectomy and the reconstruction. So these are two scenarios. Without insurance, she doesn't get the reconstruction. With insurance, she does. Is this reconstruction with insurance economically efficient? So one way that we could figure this out is, well, okay, let's just give her $40,000 and see how she spends it. If she buys the mastectomy and the reconstruction with the $40,000, then that reconstruction represents an efficient moral hazard because she's responding to having more income by purchasing the reconstruction. If instead she buys the mastectomy but no reconstruction, then without insurance she was responding to the reduced price that was created by insurance, and so the reconstruction represents an inefficient moral hazard because she would rather have the $20,000 than the reconstruction. She's revealed her preference between those two. So this is all well and good, but we're not giving people $40,000 and doing experiments every day. So let's lean back on theory. When do we know that the income effect tends to be large? Well, the income effect tends to be large whenever the commodity that's price is changing makes up a large proportion of a total spending, like housing, or say healthcare. So, maybe too much has been made of inefficient moral hazard, and the income effect is important enough that maybe it's not universally inefficient, and maybe health economists in the US should focus on moral hazard a bit less than they do. So, economists tend to hyper-focus on the demand side of this problem, though, with this moral hazard, looking at the decisions of individual purchasers. But what they don't look at so much is the incentives of suppliers of healthcare. So, one thing that suppliers have immense power to do in healthcare is to create induced demand. So what is induced demand? Well, patients lack knowledge about what's making them sick, and they also lack knowledge about how to treat it. So they're not so much selecting off a menu of options whenever they go in for healthcare. They are being guided through that menu by a professional. This makes them susceptible to induced demand. The healthcare professional or the institution that they are going to can direct them to items that, or procedures that benefit the provider more than the patient. So, Oh, double slides. So anyway, that creates an issue, is that individuals are susceptible to this induced demand. And also, putting that together with a profit motive creates kind of a recipe for perverse incentives. So, the profit motive combined with a fee-for-service system like we have in the US creates an incentive to provide the most care, but maybe not the best care. HMOs, health management organizations, were an attempt to fix this, and people just hated it. So this was, there's still a few around, but they were a system that were more popular back in the 80s and 90s, where physicians and different healthcare providers would join these organizations, and they would be paid a fixed fee by a health management organization for each patient that was under their care. And individuals would then not be paying for anything, and insurance companies, I think individuals still had copays. I'm not 100% sure on that. But point is, the compensation of providers wasn't tied directly to what services they provided. So they didn't have this incentive to induce demand for more remunerative procedures. And people just hated it, and so they've kind of fallen out of favor. And so you may say, well, okay, induced demand, maybe it's a big deal, maybe it's not, but this has very direct consequences for patient outcomes. So for instance, many varieties of knee surgery and lower back surgery don't have any scientifically supported evidence that they perform better than placebo surgery. So oftentimes, physical therapy, exercise, or medications would be more effective, but the provider has the incentive to provide the high-cost immediate solution, immediate surgical solution. But I think the best example of this I've ever heard came from a friend who's in medical physics. So So as we all probably know, one common treatment for cancer is radiation therapy. And so, they fire X-rays or some other form of radiation in the form of a beam through individuals so that they can destroy tumorous tissues. But this creates kind of a collateral dose on the way in and the way out that's damaging otherwise healthy tissue. And so one procedure that has come about to kind of help with this is proton therapy. And the difference with proton therapy is it doesn't have that exit. So they're shooting a beam of particles that kind of stick in the tumor. And so there's an entry kind of collateral dose, but it doesn't have to exit out the other side. And this is really great for some types of cancer. It's used a lot for tumors around kind of the base of the skull, but also it's really important for childhood cancer because having high doses of radiation early on in life increases cancer risk later on, right? And so if you can reduce the collateral dose for children that still have a lot of years of life to live, hopefully, then that gives them better long-term results because they may not get these other forms of cancer from their cancer treatment. And so this is really useful for these cases. Back in 2004, there were only 2 centers that did this sort of proton therapy in the US. And this makes sense because this equipment is immensely expensive. At the time, it was like $200 million for the equipment to do this therapy. But it didn't stop there. By 2017, there were 26 centers, each with their own $200 million piece of equipment. Now, luckily, there aren't enough of the types of cancer cases that this treatment is best suited for to keep these machines operating all the time. So, centers had to find new patients, and the patients that they found were patients with prostate cancer. And some prostate cancer cases need some sort of radiation treatment. But the research shows that at least over like a 10-year period, monitoring of early stage cases performs just as well as surgical solutions, radiation, or proton therapy. And so it's such a slow-moving form of cancer that largely people die of something else before the cancer gets large enough to be a problem. And so, in effect, these centers had found all of these prostate cancer patients were just very easy cases for them to kind of use these machines on so that they could finance all of these centers. And the kicker of it is that many of these patients likely needed no treatment at all. And so, in contrast to this kind of picture in the US, the UK has 2 centers. And if we kind of divide that by population, which is very crude, there's 12.6 million people per proton center in the US compared to 33.22 million people per center in the UK. And so I've not dug into it, but I think it would be very interesting to see if the UK, with its nationalized system, is also using this therapy for prostate cancer cases, given that it's not like an efficient or cost-effective treatment for that illness. So anyway, this is just I think a really great illustrative example of induced demand in healthcare, of people that likely need no treatment at all are being kind of pushed towards this very expensive treatment because it serves some sort of greater profit motive to finance this expensive machinery that we probably have too much of anyway. All right, that's all I got for this.